And I'll share the screen with you. Okay, so this is the last slide that we did yesterday, and I explained to you that when there is diastolic heart failure and when there is impaired ventricular filling, what we do is we try to increase the time of diastole. And one way to increase the time of diastole is to slow down the heart rate. When the heart rate slows down, it's the time of diastole that increases quite a bit. The time of systole also increases, but that increases very little. That is quite insignificant. So one of the ways to deal with the impaired ventricular filling is to give beta blockers that will slow down the heart rate and increase the time of diastole. And when the time of diastole increases, the heart will get more time to fill. And so the end diastolic volume will increase, and to some extent, the pumping ability or the cardiac output will also increase, all right? Let's continue with the compensatory mechanism. We have seen that for sympathetic nervous system stimulation, we give beta blockers, and to counter the renin-angiotensin-aldosterone system, we give ACE inhibitors. Now we are going to deal with endothelins, which cause vasoconstriction. And obviously, vasoconstriction is not good for a failing heart, because vasoconstriction means increased peripheral resistance, and increased peripheral resistance means the heart will need to create a greater force to eject the blood, right? So endothelins, for them, we give diuretics and we give direct vasodilators. And among the diuretics, we have bumetanide, furosemide, which are loop diuretics, and hydrochlorothiazide and metolazone. And among the vasodilators, we have isosorbide, dinitrate, and mononitrate. We have hydralazine, which is an arteriolar dilator. And these nitrates are venodilators, okay? So whenever there is volume overload, and that we can judge from peripheral edema, swelling of the ankles and the feet, and congestion anywhere we find in the body, especially in the lungs. So we use diuretics, and direct vasodilators are used to decrease systemic vascular resistance, right? Indications are pulmonary congestion for diuretics, peripheral edema. Loop diuretics are used in heart failure, but they can cause hypovolemia. But if pulmonary edema develops, which is not uncommon, right? Then you have to give IV loop diuretics, furosemide, and you might have to give an IV infusion as well. Effects on CVS, they decrease preload and they decrease afterload. And thiodiuretic, this is an important point. Thiazide diuretics lose efficacy if creatinine clearance is below 50 ml per minute. So that this below 60 ml per minute is stage 3 chronic kidney disease, right? Maybe it is 45 ml or something like that, but as the GFR decreases, the efficacy of thiazide diuretics decreases. But these loop diuretics, they are effective up to a GFR of 30 ml per minute. Below that, their efficacy also starts decreasing, okay? Then venous dilation decreases preload, and arteriolar dilation decreases systemic vascular resistance. Nitrates are most commonly used. Hydralazine in combination with nitrates is also used. You know, hydralazine decreases afterload, plus isosorbide dinitrate, it decreases preload for additional effect. This combination is more effective in patients of African descent, which we use in New York Heart Association class 3 heart failure. with decreased or reduced ejection fraction. And calcium channel blockers should be avoided because they have got negative inotropic effect and they may exacerbate heart failure. Now, I've added a couple of slides over here from my pathophysiology lectures because some students are not very clear about preload and afterload. Now, can somebody tell me what is preload and what is afterload? Any ideas? All right, I'll just go on in and I'll explain it to you. See, this woman is walking with a bucket of water. There's a certain amount of water in this bucket, all right, or we call it a pail. So this is preload. If you increase the amount of water in this pail, the weight is going to increase and the workload is going to increase on this woman, right? Now, the second thing is she's going uphill. Now, this is afterload. Preload and afterload, the steeper the slope, the greater is going to be the workload. So let me give you another example in the next slide. Preload is the end diastolic volume. You can call it the filling of the pail, of the filling of the heart. The greater the filling of the heart, the greater is the preload. You can call it venous return. You can call it end diastolic volume. And afterload is the force the contracting heart must generate to eject blood. And this is analogous to systemic vascular resistance. Actually, it is systemic vascular resistance. The higher the resistance, as in hypertension, if the blood pressure is high, there is greater pressure in the aorta and the arterioles, basically. So the heart has to generate a greater force to eject the heart. So this is end diastolic volume, and this is like the peripheral resistance. And in this video, what I'm going to show you is afterload, walking against the wind in Norway. So you can assume that the bag she's carrying and her own body weight is the preload that she has to carry. And the afterload, I'll play this video for you and you will understand what afterload is. And a failing heart is something like this, the failing heart is struggling against the afterload to send blood to the tissues, right? Now, the stronger people can overcome the afterload, but the weaker people cannot. And sometimes when the heart is too weak and it cannot overcome the afterload, we need to help the heart, okay? And you will see that there will be an old man. He will be helped by people to walk against the wind, all right? All right, so that is what happens to the heart when the afterload is too high, and that is the reason we need to decrease the afterload. And hydralazine, as I said, it causes dilatation of the arterioles. The arterioles are known as the resistance vessels, right? So we are, in a way, we are trying to augment the Frank-Starling mechanism. And how do we do that? We do that with inotropic drugs, right? So digoxin is one of them. It comes as tablets. This is the dose. It comes as injections. It comes as an elixir. And we have got dobutamine, which is beta-1 agonist. We have got infusion, we have got injections, we have got milrinone, which is also given intravenously, all right, for intravenous use only. So these are the drugs that help the heart to beat or to contract with a greater force, right? So inotropic drugs includes digoxin, dobutamine, enamrinone, and milrinone, and they have slightly different mechanisms of action. But remember that all these drugs increase contractility by increasing cytosolic calcium concentration. Now, many people believe that, all right, increasing calcium concentration does increase the contractility and inotropy of the heart, but in the long run, increasing calcium concentration reduces the life. It increases mortality. Okay, so that is why there are some new drugs that increase the contractility of the heart without increasing the cytosolic calcium. The digitalis glycosides have low therapeutic index. Even slightly high doses can be toxic. Hypokalemia could be toxic for digoxin. Resting membrane potential of cardiomyocytes can increase when positive charges go in. Normal is minus 90 millivolts. It could increase to minus 70 millivolts, making membrane more excitable, and it also increases the risk of arrhythmias. That is why digitalis can cause arrhythmias as well, although it is also used for arrhythmias like atrial fibrillation. So I'll show you the mechanism of action of digitalis. This is a cardiomyocyte. This is the cell membrane, and these are the actin-myosin filaments. I've shown you one sarcomere with actin-myosin filaments. And on the cell membrane, we have got sodium-potassium ATPases, and we have got this transporter, which is known as sodium-calcium exchanger. All right, so what happens is, if you remember the action potential of a cardiomyocyte, it has got a phase 0. When the action potential arrives, the sodium channels open and the sodium moves in. And then the second phase is slight depolarization because of potassium. But in the plateau phase, it is the calcium that moves in, right? Calcium moves in and a little bit of potassium is moving out. But what happens in phase 3 is that the potassium channels open up and potassium moves out. Before that, because of this calcium, that calcium removes this tropomyosin, which is covering the binding sites of actin filament, and the actin and myosin filaments slide over each other. It is also known as excitation contraction coupling, and we get the contraction of the myocardium. But in phase 3, the potassium channels open up and the influx of calcium slows down, and we go back to the minus 90 millivolt of the membrane potential. All right, now the thing is, as soon as the action potential is over, this sodium potassium ATPase will come into action, and it will start pumping out 3 sodium and bringing in 2 potassium, right? So it will restore the concentration of intracellular potassium and extracellular sodium. All right, I hope you are with me so far. So what does digitalis do? Digitalis actually, now before I go to digitalis, let me go back. We have got a high concentration of sodium inside before this pump is activated. Now, as soon as this pump is activated, this sodium will move out, right? Now we have got a concentration gradient. When the sodium is in, there is no concentration gradient. And this transporter works with the help of sodium gradient. So the job of sodium potassium ATPase is to restore the sodium gradient, no sodium inside and a lot of sodium outside. When this happens, this transporter is activated and sodium will move in and calcium will move out. right, as you see over here, and the heart will relax, all right? The myocardium will relax and we get diastole. So I hope this is clear so far. Now let us see when digitalis is there. Digitalis will block this sodium potassium ATPase. When this sodium potassium ATPase is blocked, sodium will stay inside. Sodium will not move out. So there is no concentration gradient. When there is no concentration gradient, the calcium that we had inside will stay inside because it went out in exchange of sodium. There was a concentration gradient, sodium moved in, and with the help of that concentration gradient, calcium moved out. But when this pump is inactivated, sodium will stay inside and so will calcium. And you know, higher cytosolic calcium increases the contractility of the heart, right? So that is the mechanism of action of digitalis. Now I'm going to ask you a series of questions, and please try to answer those questions. This is just physiology, right? And you know that digitalis comes from foxglove plant, and the leaves of this plant, they contain digitalis, right? So that is how we get digoxin. Then it has got no effect on normal heart, okay, but it has got an effect on failing heart because it increases cytosolic calcium. Now, when the cytosolic calcium increases, the force of contraction or the myocardial contraction also increases. All right. So what happens to end systolic volume when myocardial contraction increases? I'll give you two choices. Will it increase or will it decrease? Now the heart is contracting with a greater force. So what will happen to end systolic volume? And Fahad said it increases, but that is, I'm afraid, not the right answer. It will decrease because when the heart contracts with a greater force, it will pump out a lot of blood. So the end systolic volume will decrease because the ejection fraction will increase, the stroke volume will increase. So the blood inside the ventricle will be smaller in amount, okay? All right. Now another question, which is, so here there's a decrease in end systolic volume. So what happens to ejection fraction when myocardial contraction increases? Does it increase or does it decrease? All right, I got another answer, and which is decrease. It is a wrong answer. This is physiology. When the heart contracts with a greater force, more blood will be ejected from the heart. That means the ejection fraction will increase, right? So just, I mean, it's all right, but there are more questions coming. For example, what happens to tissue perfusion when ejection fraction increases? Will it increase or will it decrease? Okay, I got another answer, which is increased. Yes, that is correct. When the ejection fraction increases, that means the stroke volume increases. That means the cardiac output increases. So that means the tissue perfusion will increase. All right. And the next question is that what happens to sympathetic drive when tissue perfusion increases? Will there be a greater stimulation of sympathetic nervous system, or will there be reduced stimulation of sympathetic nervous system? Oh, yes, that is good. it will be reduced because, the sympathetic nervous system comes into action, or the sympathetic drive increases when the tissues are not getting enough blood, right? When the tissues don't get enough blood, they send messages to the brain, and the brain, through the sympathetic nervous system, tries to stimulate the heart, tries to increase the cardiac output, right? So when the tissue perfusion increases, the sympathetic drive is going to decrease, right? And the next question is, what happens to systemic vascular resistance when the systemic activity decreases? Okay, there will be reduced peripheral resistance because sympathetic nervous system causes contraction of the smooth muscles of the blood vessels, okay? Especially, yes, there will be vasodilation. That is very good. So basically, it is the arterioles that produce the resistance in the circulatory system, right? The arterioles are known as the resistance vessels, right? So digoxin increases vagal tone, okay? And vagal tone, well, the question is, when vagal tone increases, the heart rate increases or decreases? Vagus is parasympathetic nervous system, right? And perhaps it's written, it decreases, which is the right answer. So the heart rate will decrease, reduction in heart rate. When the vagal tone increases, conduction through atrioventricular node will increase or decrease. Okay, I got one answer, which is decrease, which is the right answer. And that is the reason sometimes this digoxin is used in atrial fibrillation, okay? Excuse me. Now, there will be slow conduction through the AV node. When the heart rate decreases, myocardial oxygen demand will decrease or increase. And this is pretty much straightforward. When the heart rate decreases, obviously the oxygen demand also decreases, right? So that is the correct answer. And digoxin is used for atrial fibrillation because it decreases the conduction through the AV node, all right? Now, therapeutic uses of digoxin: severe left ventricular systolic dysfunction in combination with ACE inhibitors and diuretics, right? But these days, digoxin is not used very commonly. When we were students a very long time back, then digoxin was sort of a magic drug, and every cardiologist was using digoxin. But over the time, we have found that digoxin use actually increases mortality, right? So it is not very commonly used. Now we have got different drugs that we have already shown previously, okay? So heart failure with atrial fibrillation, that is where we use digoxin. It's the only oral inotropic drug. The others are intravenous. It is not indicated in diastolic heart failure and right-sided heart failure. In patients with mild to moderate heart failure, again, they respond well to ACE inhibitors and diuretics, so we don't use. So overall, digoxin is not very commonly used these days, okay? Pharmacokinetics: digoxin is the only digitalis available in the USA. The margin of safety between efficacy and toxicity is very narrow. Like this is a Saturn and this is an angel. They come very close to each other, which is not something desirable. So margin of safety, it has got a very narrow therapeutic index. Half-life is about 36 to 40 hours. Because digoxin is eliminated by kidneys, dose adjustment is based on kidney function or creatinine clearance or GFR, okay? It accumulates in muscles, therefore it has got a large volume of distribution. Volume of distribution, we never use that clinically, all right? So that is not important. Adverse effects, the toxicity of digoxin is common, especially when there is hypokalemia. That is why we always monitor potassium levels over here. And this is just a joke over here. It says because bananas have got a high level of potassium in them. So monitor serum potassium levels, beware diuretics and hyperaldosteronism cause potassium loss. And we do have hyperaldosteronism in heart failure, because heart failure decreases the perfusion of the kidneys, and the kidneys are going to release renin in response to decreased perfusion or low pressure in the kidneys, right? So loss and decreased potassium levels predispose to cardiotoxicity. So we have to give potassium supplements. We have to monitor renal function, adjust dose based on renal function, and monitor drug level. Ventricular tachycardia is paradoxically, this is a side effect. So we have got an antidote, which is digibind antibodies, and we have to discontinue digoxin. But if the toxicity is not too bad, and if digoxin is improving the patient's condition, then you might want to just reduce the dose in some situations, okay? And arrhythmias is one of the adverse effects. You can use lidocaine or phenytoin, which are both class 1B antiarrhythmic drugs. Gastrointestinal effects are anorexia. There is already anorexia in heart failure because of a degree of edema in the GIT. So the person loses appetite. Digoxin further aggravates that. Then nausea and vomiting. It has got CNS effects like headache and fatigue, blurred vision, halos around dark objects, okay? And there are certain drugs that displace digoxin from their protein binding sites, and these are those drugs, okay? And the other thing is that corticosteroids, thiazide diuretics, loop diuretics, they cause hypokalemia, and all of these things can lead to enhanced potential for digoxin toxicity and cardiotoxicity. Okay, so we have to use potassium supplements, or we can use potassium sparing diuretics over here. So this is what we have done so far. We said that we can give diuretics in volume overload and for vasodilation, and to counter the effects of endothelins, we give vasodilators, and among them is hydralazine and nitrates. And we have got nitroprusside as well. Nitroprusside is given actually in hypertensive emergencies. It is given IV, and it has got a very short half-life. Then we have got inotropic agents, and I gave you the mechanism of action of digitalis, therapeutic uses of digitalis, and adverse effects of digitalis, right? So let's do this question. I want you to read this question yourselves. All right. All right, so I can tell you that this is a case of digoxin toxicity, right? Because all these are signs and symptoms of digoxin toxicity, and particularly when the potassium, digoxin actually competes with potassium to bind on the sodium potassium ATPase. I said that digoxin blocks sodium potassium ATPase, but the binding site for digoxin is same as sodium potassium ATPase. So one answer is to discontinue digoxin and start milrinone. I don't disagree with you. This could be a possibility, but another possibility is to add potassium. You must add potassium supplementation, right? Not just giving another this inotropic drug is not enough. See, the potassium level is low, and it is this low potassium level that is causing digoxin toxicity, right? So, and we see that it is written the disease was well controlled with captopril, furosemide, and digoxin, which means that the digoxin was working well with this patient. So I would say that adding potassium supplementation is a must, right? You must correct the potassium levels. After that, if you want to discontinue, you discontinue that, or if you want to reduce the dose, you reduce the dose and monitor the patient. The patient must be there in the cardiac care unit, and he has got all those monitors attached to him. All right. So, so there is a clinical pearl which says that think twice before discontinuing a drug that works for the patient. All right. Decreased renal function, increased serum digoxin levels, and low potassium also increases the toxicity of the digoxin, right? So both for this, you cannot do much, right? We do not know why the creatinine level is low. Maybe the patient has got chronic kidney disease, but at least you can give these supplementations, and this should be the best option. But if in your experience it is something else, that is perfectly all right. Okay, let's look at this question. All right. All right, so I'll answer this question for you. There is an answer which is D, and that is a very good answer. See, this furosemide has got nothing to do with angiotensin 2 synthesis, okay? Furosemide is going to decrease venous return because it is going to decrease the volume in the body, okay? It causes diuresis. So it will not increase venous return, it will decrease venous return. They inhibit renal prostaglandin biosynthesis. Furosemide has got nothing to do with it. They are effective even at low GFR. I mentioned previously that up to a GFR of 30 ml per minute, furosemide and these loop diuretics are effective. They increase the contractility of the failing heart. No, they have got nothing to do with the contractility of the failing heart. All right. So why is GFR low in this case? GFR is always low in heart failure when the organ perfusion is low, right? So when not enough blood is going to the kidneys, there will be not enough GFR because the pressure in the kidneys and in the glomerulus is low. All right. So now we go to dobutamine and dopamine and milrinone, which are inotropic agents. They are dobutamine and dopamine, at least dobutamine. This is dopamine agonist, okay? Dobutamine is beta adrenergic agonist. And this is a donkey which is working all the time, and it is carrying a load. Now, if you want to work it more, you must feed it something good, right? So that it keeps on working. So we have got two types. We have got beta adrenergic agonist, and we have got phosphodiesterase inhibitors, right? They increased contractility. Now, dopamine at higher doses, it is an agonist of the beta receptors as well. Okay, otherwise dopamine is an agonist of the dopamine receptors, but at higher doses, as you increase the dose, which is something like 20 microgram per ml, then it increases, it has its effect on beta receptors. And they cause vasodilation because stimulation of beta-2 receptors causes vasodilation. Stimulation of alpha-1 receptors on the blood vessels causes vasoconstriction. most, in the blood vessels, we mostly have alpha-1 receptors. We have fewer beta-2 receptors, but the effect of beta-2 receptors is vasodilation, and they are given intravenously. These drugs, milrinone and enamrinone, they are phosphodiesterase. Phosphodiesterase is the enzyme which destroys cyclic AMP, right? Maybe I have got the mechanism of action in the next slide. I'll show that to you. So these are phosphodiesterase inhibitors. So they will prevent the degradation of cyclic AMP and they will increase the concentration. All right, there is a little bit of noise, so I'll mute all the people. Okay, right. So in that increased cyclic AMP is going to increase cytosolic calcium concentration, because cyclic AMP through protein kinase A increases the release of calcium from the sarcoplasmic reticulum. Okay. Right, and increased contractility because of increased calcium concentration, and a short-term use is recommended for these drugs, right? So we don't use them for a very long period of time. And here is the mechanism of action of beta-adrenergic agonist and phosphodiesterase inhibitors. So again, this is the cell membrane of cardiomyocyte. This is the nucleus and endoplasmic reticulum, which stores calcium in it. You can call it sarcoplasmic reticulum. And these are the G protein coupled receptors to which these drugs bind, not the drugs. The drugs also bind to these, but epinephrine and norepinephrine also bind to these, okay? And beta-1 receptor is G stimulatory. It is G alpha S. This is also G alpha S. So these adrenergic beta-1 and beta-2 receptors are stimulatory G protein coupled receptors. This is a potassium channel. Sorry, this is a calcium channel. And we have got a higher concentration of calcium outside the cell, right? And this is the enzyme adenylyl cyclase. What is the job? What is the function of this enzyme? It converts ATP to cyclic AMP, right? So epinephrine, norepinephrine, dobutamine, dopamine, they bind to these receptors. And as a result, G alpha unit dissociates from G beta and G gamma. If you remember the working of these G proteins, and it will bind to adenylyl cyclase, and adenylyl cyclase will be activated and it will convert ATP to cyclic AMP, right? And this will downstream, this will activate protein kinase A, and protein kinase A has its effect on this ryanodine receptor on the sarcoplasmic reticulum and also on the calcium channels. So the end result of all this is that calcium will be released, not only from the intracellular stores, it will also come in from the extracellular reservoirs or from extracellular space. So we get an increased concentration of calcium. That means the force of contraction of the heart is going to increase, right? Now this enzyme phosphodiesterase is activated when there is high calcium level, and this phosphodiesterase destroys cyclic AMP, right? So when you destroy cyclic AMP, all these effects will not be there. So that is why if you inhibit phosphodiesterase with enamrinone and milrinone is the one very commonly used, you will, have a higher concentration of cyclic AMP and you will have a higher concentration of calcium inside the cell. All right, so that was the mechanism of action. And this is sarcoplasmic reticulum calcium ATPase. It moves calcium back into the cells, but that is not a part of what we are discussing right now. Okay, and eventually, it will sort of move the calcium in, and the calcium concentration will go down over here. So that was about this augmenting or helping the Frank-Starling mechanism to work. Okay, because in heart failure, we go beyond the normal limits of Frank-Starling mechanism, and the heart cannot contract because it has dilated so much. Now we go on to the last point, or maybe not the last point. There are other drugs as well, which is myocardial hypertrophy and remodeling, which means fibrosis is remodeling, increase in extracellular matrix proteoglycans and glycosaminoglycans that happens in heart failure, and that is the effect of aldosterone on the heart. Dilatation of the heart is cardiac remodeling. Hypertrophy of the heart is cardiac remodeling. All right. So we have got these drugs which are aldosterone antagonist. We have got eplerenone and we have got spironolactone. Okay. And again, there is a warning that in heart failure, you must routinely assess potassium levels and renal function. And as I said, that because the perfusion of the kidneys is low, the heart is failing, the heart is not pumping enough blood to go to the tissues and organs. So the pressure falls in all tissues. And when the pressure falls in the kidneys, the granular cells are going to release renin. Renin will convert angiotensinogen to angiotensin 1. And angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. And angiotensin 2 has got so many effects like vasoconstriction and sympathetic stimulation. And it also causes aldosterone release, right? And aldosterone and even angiotensin 2, they cause remodeling of the heart, right? So there will be reduced hepatic clearance of aldosterone because perfusion of the liver is also low in heart failure, okay? So all these things will lead to higher aldosterone levels, right? And because aldosterone is metabolized in the liver, okay? So if the metabolism is low and the production is high, then we are going to get elevated levels, okay? Both aldosterone antagonists can cause life-threatening hyperkalemia. So because aldosterone, anybody remembers the action of aldosterone? What does aldosterone do in the body? Any ideas? It is a mineralocorticoid. What does it do? Right, aldosterone retains sodium and water in the body. When we come to diuretics, I'll explain that to you. And aldosterone causes excretion of potassium. It causes hypokalemia, right? So when you block aldosterone with these drugs, there could be hyperkalemia, right? And hyperkalemia is also not good for a failing heart. So adverse effect of spironolactone, gastric disturbances, confusion, gynecomastia, because spironolactone is aldosterone antagonist, and it blocks these adrenal androgens as well, okay? So it can lead to gynecomastia in males, decreased libido, menstrual irregularities in females, right? Eplerenone, due to reduced affinity to mineralocorticoid receptors, it has got lower incidence of endocrine side effects like gynecomastia or the other effects, okay? Reduced mortality in left ventricular systolic dysfunction and acute myocardial infarction. So the bottom line is that both these drugs are used, and here is a question: list 3 endocrine adverse effects of spironolactone. All right, so they are already written over here. You can just gynecomastia, decreased libido, and menstrual irregularities. And the other question is, which of the following drugs reduces mortality in myocardial infarction? Is it spironolactone? Is it eplerenone? Or are these beta blockers? Right. So, you know, it is written that reduces mortality in left ventricular function and in acute myocardial infarction. So B is the correct answer, but C is also correct. You know, in the long run, if you start beta blockers after myocardial infarction, they also reduce mortality in the long run. Okay, and I previously mentioned 3 drugs, which was metoprolol, bisoprolol, and carvedilol. Okay, but obviously from this slide the answer is eplerenone. Right, let's look at the aldosterone effects on the heart. Many adverse effects on the heart, right? Myocardial fibrosis and remodeling. And fibrosis is always irreversible. Then it has got a lot of different effects. Increase in left ventricular mass, right? When the mass increases, the cavity size will decrease. You know, if the wall becomes thicker, the cavity size will decrease, and this increase in mass is not increase in the number of actin and myosin filaments. This is increase in extracellular matrix like glycosaminoglycans and proteoglycans, right? Hyaluronan, I'm sure chondroitin sulfate, all these things, you know, heparan sulfate, these are glycosaminoglycans which are deposited in the extracellular matrix. Decrease norepinephrine uptake. You know, norepinephrine, when it is released, after its action, it is reuptaken back by the nerve terminal, if you remember that. You know, we have got cholinergic nerves and we have got adrenergic nerves. Cholinergic nerves release acetylcholine, but acetylcholine after release is destroyed by acetylcholine esterase. But this norepinephrine and dopamine, these catecholamines, they are reuptaken back, they are recirculated, they go back into the nerve terminal. All right. So impaired endothelial functions. Endothelial cells are the cells lining the blood vessels, and increase in plasminogen activator inhibitor, which means it is going to increase clotting. So all of these are bad effects, right? And there is a risk of increased ischemic events and a risk of increased arrhythmias because of these catecholamines, okay? And that could lead to sudden cardiac death, right? So let me do a quick summary for you. We have done these inotropic drugs. I showed you the mechanism of action. We did these aldosterone antagonists, and we looked at the effects of aldosterone on the heart. All right, so actually we have gone very slow. We went into a lot of details, which is in a way good because you understand things, but it takes a longer time. So because our time is over now, so we will stop here. And if you have any questions, you can ask me. All right, so I assume there are no questions. So we will call it a day over here and we will decide for the next lecture. All right, so thank you very much and I'll see you tomorrow.